So, Andre, thank you so much for joining us today. Really grateful and really intrigued and happy that you're doing the work
Mm.
that you are. Thank you so much.
Well, thank you, everyone. Really, really honored to be invited to give this talk to One Pair States. Y'all are, I think, I would say, of all the orgs out there working on this issue, I feel that One Pair States is the one that I kind of share the most with when it comes to this sort of grand vision. And I'll go ahead and share my screen and start the presentation because it has a slide for my introduction. I just want to verify because I didn't hear the thing say that the recording is started. Is the recording started? We're good? Okay.
Yes, it is.
Looks like we're good.
Mhm.
So I'm just going to share my screen. Oops. I was trying to get some last minute stuff in there for you. Didn't succeed. So let's go to the beginning. Okay, so just to give a bit of context on this presentation before we jump in, this was a presentation given to the Universal Healthcare Commission of Washington State. That is a statewide commission created about a year, 2 years ago. I'm not quite sure when. I think it shows up actually on a timeline slide, so we'll be able to get that right. The presentation was given on August 10th. And we've seen some really, really solid response to it since then. If you want these slides, you can go to wholewashington.org/UHCC-presentation. You can grab them there. Theoretically, we might get some other supplemental materials up there at some point, including the video. It was matter of public record, so the presentation to the commission is also viewable. So I'll try to get that up there so that y'all can watch the original presentation if that interests you, although the content will be very, 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 very similar. Since this is a policy and strategy group, I might mix in just a little bit more strategy, whereas we are very, very focused on just the policy when presenting to the commission. Okay, so myself, my name's Andre Stackhouse. My academic and professional background is in information science. I worked in the tech industry at companies as small as the local nonprofit startupcode.org, which is focused on computer science education in the public education system, and then companies as large and as notorious as Microsoft. But politically, I've been in the game since about 2016. That was the first time I picked up a phone or knocked on a door. So I really started as just a grassroots volunteer. By 2020, I was elected to represent the Democratic Party as a delegate at both the state and national convention, where I got to work very hard to make sure that universal health care was included in the party platform. And then I was a co-founder of a group called Medicare for All Everywhere, which some folks in here may have heard of. Bears some similarity to One Pair States. And then Whole Washington, I was the campaign director of our last ballot initiative, I-1471. And I now am the executive director, still a volunteer, but we don't have an active initiative campaign right now. So we're focusing more on the sort of infrastructure, public outreach, organization, really building up for our next big moves. When I gave this presentation to the commission, I was very fortunate to be joined by Erin Georgian, who is one of our top policy consultants, who has been involved in the drafting of every version of the Washington Health Trust, and really has deeper policy chops when it comes to this stuff than pretty much anybody that I know. Although I'm sure some people in this room could give her a run for her money. But I don't have her backing me up in the Q&A this time, but I'll do my best. But if you have any really, really hard questions, I can maybe shoot them to Erin and see what she has to say about it. Okay, so for anyone who hasn't heard of Whole Washington, we are 501c4 statewide organization founded in 2017 with the goal of advancing universal public health care at the state, regional, and federal level. The organizers behind the Washington Health Trust, which is the policy I'm going to be really breaking down the nuts and bolts of in this presentation. And that policy has had multiple iterations in both legislative and initiative form. And so we really are best known for our ballot measures, but we always want to make it clear that we 100% support any work being done on this issue, especially in the legislature. We would love for them to hear what we are proposing, to make policy and pass it, and frankly give us our weekends back. But we work on this issue wherever we see potential for movement. And I want to give a special thanks to Senator Bob Hasagawa, who has been the primary sponsor of every legislative version of the Washington Health Trust and has been just an incredible advocate for this issue since before I was working on it. Okay, so to set a little bit of context for the version of the Washington Health Trust that we have today, and this is a sort of brief history of healthcare politics in Washington State. So 2018 was the first ballot measure that whole Washington ran, I-1600. This was an initiative to the people, and so in many ways it was less realized as policy written to a high sort of legal standard, but it did outline the broad design of the Washington Health Trust. We collected over 200,000 we collected over 100,000 signatures, did not make the ballot, but we did take the Washington Health Trust and introduced it into the Senate in 2019 as Senate Bill 5222. And this began a process in which we were able to access more legislative resources. We were able to get it reviewed by the Department of Revenue, and so by 5222, this initiative is beginning to take the form of legislation and policy. In Washington State, that's the same year that the Long-Term Care Act was passed. This was some taxes and benefits to cover long-term care. To be totally frank with you, the Long-Term Care Act has been highly criticized. It is seen as very, very incomplete for the scope of the problem it is attempting to address. And this is relevant to the Washington Health Trust because in many ways we're taking many of these programs, many of these revenues that have tried to take a small piece of this problem and really create a unified system in which everyone's needs are met and the financing is always there. So another one of these is Cascade Care. This was a supposedly public option. This was really initiated by Governor Inslee, who I will just say was running for president at the time. And this was widely reported, including in fairly reputable publications like Vox, as a I don't quite want to use the word revolutionary, but a first of its kind public option at the state level. I don't need to go too into the details into this, but I think that Cascade Care does not quite meet the definition of a public option. For a start, I'm not eligible for it. It doesn't have universal enrollment. It covers very few people. And so while it did raise certain subsidies and eligibility thresholds, we're really still talking about a program that is targeted at the low to lower middle income and not something that approaches universal or open to the general public. 5399 in 2021, that was the bill that created the Universal Healthcare Commission. And originally the commission was a temporary commission that would span, I can't remember originally, but 3 to 5 years, something like that. And at the end of that process would be making a recommendation to Washington State's legislature for a design and implementation of a universal healthcare system at state level. By the time it was passed, it had been made into a permanent commission. And so that commission meets monthly. It has a finance technical advisory committee that also meets monthly. The commission meets bi-monthly, and they release a report every November. So they've released one annual report. In that same year, we reintroduced as an initiative and legislature I-1362, 5204. We made some tweaks. I don't think it's necessary to go through every single change that happened along the way. That's the same year that Washington introduces its capital gains tax, though. And so that's highly relevant. Capital gains is one of the revenue sources that we propose in the Washington Health Trust. And that was seen as fairly controversial when we first started talking about it. But by now, not only has Washington State introduced a capital gains tax, but it has also been upheld by the state Supreme Court. So that was in 2023, which really puts that revenue stream into firm legal precedent. I also have a little shout out here for in 2022 acquiring a 1332 waiver, which allows us to much more easily use our state programs to cover undocumented residents, which is essential to creating a universal system. And waivers are often put forward as this kind of show-stopping problem. You'll never be able to achieve universal health care because you need this cooperation from the federal government, because you need these waivers. And we just include this in this timeline because it just goes to show you that these waivers do exist. They can be acquired. They're being acquired right now. So in many ways, the system that we are going to propose has been coming into place for many years. And if we were to extend this timeline backwards, you would see its lineage going all the way back to the I can't remember what it was called, the 1993 healthcare reform bill that actually passed along the Clinton care push of the 90s. Washington State was one of the only states that I know of, along with Vermont, that has actually passed something like a universal single-payer healthcare system. It wasn't quite single-payer. It was more of an employee mandate. But all the way back to the 90s, Washington has been working on this, and that became the Washington Health Security Trust that many people at Healthcare for All Washington worked on, which was what the Washington Health Trust was based on. So we're always trying to build off of the work that has been done in the past, take the best lessons from it, and create legislation that is up to date, that is cutting edge, and that is well set up for success. So this goal slide was maybe more relevant to the commission because we were largely saying that our goal was to begin a dialogue that we hope is ongoing, and that we would be co-developers of universal healthcare policy that gets recommended and passed to the Washington State Legislature. But we're going to go over, what we mean when we say universal healthcare, how our bill works. We're going to talk through known barriers like ERISA and waivers. We're going to leave some time for questions. And then when it comes to the commission, our real hope for a next move is to get a more detailed meeting with the Finance Technical Advisory Committee to really go into the details of the revenues, the costs, and show with plain numbers how this truly saves money for the people of Washington State. So starting with that definition, we really like to use the World Health Organization definition because we think it targets key outcomes that we hope to see from a universal healthcare system without being highly prescriptive on how those are achieved. So they say universal health coverage means that all people have access to the full range of quality health services they need when and where they need them without financial hardship. So identifying key outcomes: universal eligibility, either automatically or through enrollment, universal benefits, so you don't have a tiered system where some people have much better benefits than other people. Everyone has a high standard and a fair standard. Uniform billing and reimbursement, so you don't have some people paying way more than other people. You don't have the same procedure costing way more for one person than another person. This is very, very important to making sure that the costs are equitable. Significant public funding and nonprofit. So these, I think, are the two biggest differentiators from what we might be proposing to what we currently have, which is to say we have a very large private healthcare industry. We have a very predatory private health insurance industry. And we're really talking about public healthcare. We're talking about public insurance, and we're talking about deprivatization of healthcare. Not entirely, not instantaneously, but we basically believe that the profit incentives in the current system contribute to significant cost inflation as well as inequality in the system. This is getting a little bit more at the poetry of it. What is the point, right? And so that, of course, this is a Martin Luther King quote. I live in King County, Washington, which is named after Dr. King. This famous quote that I'm sure most people in this room know: of all the forms of inequality, injustice in health is the most shocking and inhuman because it often results in physical death. And that just reminds us of the stakes of the work that we're doing here. It reminds us of the stakes of the action that we take, but also the action that we do not take. This for me is a reminder that we're not just talking about cheaper healthcare. We're not just talking about more convenient healthcare. We're talking about a more just healthcare system, and by extension, a more just society. Okay, so this is some of the previous work that was done by the Universal Healthcare Work Group. This work group actually predates the commission, but the commission very much is a continuation of it, I would say. And this work group basically studied different models of universal healthcare in Washington state. And so they looked at 3 different systems, A, B, and C. Model A, we could kind of call state single payer. It's a unified financing system. It's publicly funded and publicly administered. Model B is state governed, and it's a state governed health plan, but it's administered through private insurers. So a little bit more of a hybrid model there. And then Model C, if I understand correctly, effectively was to maintain much of the current system, but to subsidize it with expansion to coverage for undocumented residents and other other ways to subsidize and expand access. But I will say that if you look into the report, Model C sort of openly states that it's not truly intended to create a universal system, at least not a universal public system. And what this work group found was that the greatest savings was in the simplest and most streamlined system, which is Model A, single payer. And you see there cost savings estimated at 2.5 billion in the first year and up to 5.6 on an annual basis. Model B saving less, but still, in the millions, hundreds of millions. So we looked at this work group report and thought that it was really quite favorable to the work that we are doing and what we propose. So the Washington Health Trust, taking it from values and goals up to models, right? The Washington Health Trust is policy, because we think that what comes next is policy and legislation. So this is where we really outline not just a model, but a healthcare policy. And so, as I said, this was originally based on the Washington Health Security Trust, developed by Healthcare for All Washington. Some of the things that we have added is the financing plan for it, which we co-developed with Dr. Gerald Friedman, an economics professor at University of Massachusetts Amherst. The technical language has been reviewed by the Employment Security Department and Department of Revenue. And then we added key provisions found throughout the bill, but largely in Section 101, which have been inspired by core values expressed by community organizations, providers, and individuals. And these are things that we have learned through literally dozens of conversations with grassroots organizations, as well as thousands of conversations with people out on the street as we collect signatures. And I'm proud to say that even as campaign director of Whole Washington, I was able to collect over 2,000 signatures personally. And you learn a lot out there, and you really understand what it is that people find frustrating about the system, what they find scary about the idea of change, and how you can reassure the public that this is something that is truly going to make all of our lives better. So what is the Washington Health Trust? It basically, it's about a 60-page bill. It's not actually that bad of a read. I do recommend that you, if you're trying to up your game, give it a read. But effectively, it comes down to 3 pillars. So the first is the creation of public options, and there are already public options like Medicare, Medicaid, but the idea here is that there would be a public option for everyone. So you are not forced into private health insurance. There is a public option available to you that you may enroll in. The second is the generation of the revenue, and that's entirely through public financing. I will say that one of the key components of this is an employer healthcare spending requirement, and that is where the bulk of the funding comes from, but there are a few sources of revenue. And we'll get more into that required employer spending. It is not necessarily into a tax for public health care, but they will be required to spend per employee. And then the third is the creation / coordination of state infrastructure that really makes sure that there are, the right authority and responsibilities that are able to sort of maintain this system. So in more of a nuts and bolts sort of way, what does the legislation do? I mean, the first thing is it creates the Washington Health Trust, which is effectively a bank account. It creates that unified financing system. So the revenues go in, the reimbursements go out. There's not that much to it. Then it creates the Washington Health Trust Board. This is going to be the sort of primary governing entity of this board, and it's going to be given quite a lot of leeway to design this system and kind of run it the way that it kind of sees fit. And so they're going to really have a lot of say over the essential health benefits package. And they're going to be doing important work like conducting negotiations, collective bargaining negotiations with providers. They're going to be coordinating with other parts of the state government. They're going to be contracting with the Centers for Medicare and Medicaid Services. There's a lot of work and authority that goes into the board. The next thing is it creates some transitional health options programs. So this is, a public option that is designed to cover gaps, especially around the uninsured, underinsured. Another transitional program that will be created is actually a Medicare Part C and D plan, which will help people who are covered by Medicare participate in this system. And then it will establish funding mechanisms that will be through the tax system and enforced through the Employment Security Department and Department of Revenue. Okay, so in a nutshell, we believe that this makes the Washington Health Trust an all-payer model with a pay-to-play requirement for employers. It includes public options for Washington residents, public health funding for participating community health providers, as well as the financing and transition plans to achieve universal coverage. And we'll come back to this, but going back to those 3 models, Model A and B. So if you recall, Model A was state single payer. Model B is basically this all-payer model. We believe that an accurate way to understand this is that at the time of its passage, it would be more of a Model B. But through its transition and through dedication to this system, its development and expansion, that it can achieve Model A, state single payer. And we're going to really show you what that process looks like. So these design components were developed by the Universal Healthcare Commission. And so you can see these different parts that we need to understand, right? Eligibility, governance, financing. We're going to go section by section and show how our proposal works with regards to these different components. And then we add a little extra for transition because that stuff is fairly specific to the Washington Health Trust, and it's more part of the transition and not part of its final design. So starting with governance. So one of the first things that will happen is the Washington Health Trust Board will be created. And there's a few things to understand about this, which it's effectively, largely governor appointed, if I remember correctly. And it has certain requirements. It has to have members of the House and the Senate. It has representation from both parties. So there are requirements on what this board looks like. But the members of the Universal Healthcare Commission are going to be given the option to immediately be appointed to the board. So we basically noticed that the Universal Healthcare Commission is a board that looks very much like the board that we proposed. It was appointed by the governor. So instead of creating a whole new board and kind of starting from scratch, we said it makes sense to transition the commission into the board. It will also be expanded to include some new members, and then it will begin to create committees. So there will be a citizen committee, which will be publishing reports and holding public meetings so that there is public oversight over everything. There will be a provider committee that's going to be facilitating collective bargaining agreements with healthcare providers and negotiating reimbursement rates for care. Very, very critical. And then there's a finance committee, which will be managing the trust and maintaining its solvency. And we believe that the Finance Technical Advisory Committee that has already been formed really looks quite a bit like this committee. So in that sense, we see parts of this infrastructure already in place. The Washington Health Trust Board is kind of going to be one strain of the double helix that is the Healthcare Authority. So the Healthcare Authority is a public system, institution in Washington that plays a very critical role in our current healthcare system. For me, they are the maintainers of Washington Health Plan Finder, which is the tool that I use to enroll into Medicaid, or Apple Health as we call it in Washington. So they play a critical role in the enrollment into our public services. They coordinate the many different parts of the Washington state government to try to make participation in our healthcare system as easy and accessible as possible. So it's really going to be the board and the Healthcare Authority that together are going to sit atop this universal healthcare system and make sure that it's working for the people of Washington. And they very, very critically, they play a role in the integration, right? So the integration of state programs, integration of that funding, the eligibility, the enrollees, but then the same at federal level. So they will be the ones who integrate Medicare with the Washington Health Trust. They'll be the ones acquiring those federal waivers. Okay, so getting into eligibility, that's the who. Who is eligible for this? And as a universal system, we of course think that the answer is everyone. It's not really a universal system unless, like that WHO definition, there's universal eligibility through enrollment. So all residents of Washington will be eligible to enroll. And when we say residency, we're using Washington State's definition of residency, which is 30 days. It will also include some non-residents, including students who may be attending school in Washington, including workers who may be employed in Washington but do not live in Washington, and then certain family situations, a dependent or a spouse or family member may be an eligible non-resident as well. Same deal for employers. So all employers in Washington are eligible to participate. And they basically do this by paying into it. You pay into the trust and your employees are now able to enroll. This can be done for all employees, or it can be done on a per employee basis. Very, very notable, an employee is able to enroll without the participation of their employer. It's up to the employee. and the employer can choose to offer different coverage as well. So it has no impact on an employer's ability to provide employer-sponsored health insurance if that's something that they would like to do. And it has no impact on an employee's ability to enroll in the system, whether or not they're covered by something else. So all employees are eligible, all employers are eligible. Benefits and services, so that's the what's covered. And again, like that eligibility section, we think it's everything. Everything medically necessary, everything that you need. So hospital services, ambulatory, prescription drugs, mental health, lab work, reproductive care, pediatric care, long-term care, dental, vision, hearing, rehabilitative care. Basically, we define this as the essential benefits package, and the idea here is that if you need the care, it is covered, and you're not going to need to seek additional coverage elsewhere. You're not going to need a supplemental plan. You're not going to need to pay out of pocket. It's intended to cover everything. And this is one of the key responsibilities of the Washington Health Trust Board. We do define in legislation the essential health benefits that you just saw, but the Health Trust Board will be given the authority to expand that if they choose. And there are existing regulations for contracting with the Healthcare Authority. So this essential benefits package was designed to meet the criteria required for contracting with the Healthcare Authority, just to make sure that there wouldn't be difficulty working through that entity. And one way that we like to think about this, and this is going to be one of the jobs of the Healthcare Authority, is that we effectively want this essential benefits package to set a standard for all state plans. And so while there's maybe a very complicated back end because there's all of these different programs, right? Effectively, if you're enrolled in one of Washington State's public programs, you should be able to expect that you are covered by this essential benefits package. And on the back end, maybe the program's Medicaid, maybe it's the health options program, right? Maybe the funding is coming from this place, maybe the funding is coming from that place, but to the user, all they know is they enrolled in the plan and they're covered by the same essential benefits package that everybody else is. Okay, providers, reimbursement and participation. How do providers fit into this system? So again, all licensed providers, if you're licensed to give care in Washington, you are eligible to receive reimbursement for anyone who is enrolled in the trust. So there's basically a couple different ways that they can participate here. And some of these slides, I'm going to just throw this out there now. This is the stuff where Aaron really did more of the heavy lifting in the presentation and knows the language and terminology really, really well. But effectively, they can accept the fee-for-service rates set by the Washington Health Trust Board. I think key thing to understand here is that a provider, if they accept the reimbursement, that's their way of participating. That is how they get included in the collective bargaining agreement with the Health Trust Board, where they can negotiate the reimbursement rates. So basically, non-participating providers will not be a part of that collective bargaining agreement. And that really gives providers a strong incentive to participate. It's if you accept the reimbursement from the Washington Health Trust, you will have say in how it works. And the reimbursement rates are going to be negotiated with providers and the Washington Health Trust Board. But anytime we make an estimate, we have different financial analyses and stuff, we're basically assuming a reimbursement rate that is on average just slightly higher than Medicare. Medicare is widely accepted health insurance. It reimburses at about the rate of Premera, and we think sets reasonable expectations for reimbursement rates, though they will be negotiated later. And sort of similar to what we were saying earlier about alignment on benefits, we're basically also trying to establish alignment on reimbursement rates. So we want all reimbursement rates for state managed plans to basically be uniform. And that will be using fee for service as well as global budgeting. You know, I'm not as much of an expert on global budgeting, but effectively, you know, fee for service may not be as realistic of a way of reimbursement for certain parts of Washington State where, you know, there may be a lack of providers, there may be a lack of infrastructure and services. And so global budgeting gives us a means to create more equitable coverage for people who may not be in as covered of an area. Okay, cost containment. So costs are one of the biggest problems that we're trying to address. You know, that's because we have the most expensive healthcare system in the world. It's the #1 cause of bankruptcy in both Washington and nationally. Cost controls are necessary to bring down the spiraling costs of the system. And this is an area where we do not necessarily define strictly in legislation. This is, again, one of those areas where we grant that authority to the Washington Health Trust Board. So while we don't legislate the cost controls directly, we do legislate that it is the responsibility of the board. We give them that authority, and we make sure that it's specified that they must enact cost controls without limiting access to or reducing quality of care. That said, there are kind of two key components that we do think address costs. And that is basically that the #1 cause of waste in the existing system is administrative waste. And so by establishing a single essential health benefits package, we simplify the system considerably. There's not nearly as much work that needs to be done on what's covered, who's covered, is this covered? The answer is yes, and then you can move on to care. The second side of this is a huge amount of money goes into billing because of the complexity of reimbursement. Is this covered? How much do we reimburse for? In what ways are costs covered for the, in which ways are costs shared with the patient versus covered by insurance? How much money gets spent, trying to collect that. And so by creating uniform reimbursement, we simplify billing considerably. And so this is where we see a lot of the reduction in cost is coming through the efficiency that comes from creating a much simpler system that's much more universal. Financing. So that's the costs. What about the revenues? I wish I had the slide for it, but before I go into how will we pay, I always like to start with what will we not be paying, right? And so for anyone enrolled in the Washington Health Trust, they'll no longer be paying premiums, deductibles, copays. We effectively shift that private spending into public spending. This is the set of public financing that we propose. The bulk of it is this first row. So this is an employer contribution. It's 10.5% based on employee wage. So 10.5% per employee based on their wage. And if you compare that to the rates for providing employer-sponsored health insurance to a workforce, this is really quite competitive. It is not at all uncommon for an employer to be paying 12% or higher. And on top of the fact that it's a competitive rate, it also completely relieves the administrative burden, the unpredictability of costs, which go up and down all the time with private insurance. Instead, it sets a steady 10.5% that can be budgeted for and relied on. And in fact, employers may even deduct up to 2% of that from employee payroll, lowering their contribution to 8.5%. And so you can see this next row. The important thing to understand is you do not add that 2% to the 10%, you subtract it. And so an employee may be contributing up to 2% as a payroll tax. So this is a payroll deduction, so it at least moves it away from that out-of-pocket expense. I should say this again. The Washington Health Trust eliminates all point-of-service costs for care. And so you'll never have to wonder when you walk into a hospital if you're going to be slapped with a big bill when you walk out. And employers can cover this 2% as an employment benefit. And that's actually something many employers want to do. They think of their health insurance as a benefit of employment. And this is a way to sort of maintain that. That same 2% is applied to sole proprietors. And then an 8.5% capital gains tax. And that's really, really intended to make sure that the most affluent in Washington state are contributing a little bit more into this system. We do exempt the first $15,000 as well as other things like home sales, retirement accounts, and more. And I want to say that in Washington state, our analysis found that about 90% of Washington actually makes less than $10,000 a year in capital gains. And so while this already really does target the most affluent individuals in Washington, the development of the capital gains tax in Washington, in which it has now been passed, and exempts the first $250,000 of capital gains, in our opinion, sets some new legal precedent. We only exempted $15,000 because we believed that Washington's tax code, which, by the way, is the most regressive tax code in the country, I'm sorry to say, that might not be the case anymore now that the capital gains tax has passed, but for many, many years, it was famously the most regressive tax code in the United States. And that makes it very challenging to create progressive funding structures for even something as important as healthcare. So we believed that $15,000 was the only way to maintain uniformity. But now that the Supreme Court has upheld an exemption up to $250,000, we believe that this is really open to reconsideration. And so we are willing and hoping to work with the legislature, to work with the Healthcare Commission.
Have you heard Texas and an anonymous plaintiff are trying to use the courts to shut down PP health centers? Reply Y or N Antioch PP.
Not sure where that came from. It'd be great if non-speakers could mute, but I will try to answer as many questions as I can when I can get to them. Anyway, we believe that this raises the revenue necessary through the public financing system in Washington state, but we think that there are many, many different ways that this could be funded, and we are very open to them. This visualization just shows the way that the spending is shared between employer and employee. So you can see it's really 10.5% that the employer is on for, and up to 2% in deduction that may be paid by the employee, which lowers the employer's contribution to 8.5%. And then this just shows what that kind of breaks down. So you can see in this light blue, that is the employer tax, and this is assuming an 8.5%. So if every employer chose to put the full 2% onto the employee, it would look like this, with maybe about 3/4 coming from that employer tax, about, another kind of sizable chunk coming from that 2% employee tax, and then frankly, a pretty small sliver coming from capital gains. So anyone out there, investors who are freaked out by this, we're really not asking for that much. We do have some ability to make this a little bit more graduated than that. So we do have a graduated exemption, the math on that is not that interesting, but this just shows you at different income levels kind of what the contribution breakdown looks like. So up to $12,000, there's absolutely no contribution for the employer or the employee. And you start to see when you hit close to the median, $60,000 is close to the 50th percentile in Washington. that employer might be paying, $500, $400 to $500 on their employee. And the employee, no more than $100, and that's on a monthly basis. Actually, these would be paid on a quarterly basis, but we broke it down by monthly just so it's a little easier to compare to monthly premiums. And then you can see it scaling up, as you go higher up the income chain. But really, $275,000 a year, you're in the 90th percentile. Still might be paying nothing a month as an individual if your employer covers it, but contributing more into the trust. And to give a little bit of context, the average Washington employee earning about $57,000 annually, and they might be paying a monthly average of $475 for an individual plan, and over $1,000 for a family plan. And the employer, that's going to be $7,000 over almost $8,000 for single coverage and $22,000 for family coverage, and an annual.
Booster
And that's
shot polling. If recommended by the CDC, will you get another booster shot? Yes, no.
Mike, can you mute everybody who's not, everybody other than Andre? This is Chuck. And Andre, just to give you a heads up, we're down to 10 minutes for the total time for today. So I don't know if we're going to be able to do any oral. And I do have to make a couple of quick announcements regarding the Sabuc rollout with Rokana. So if you can wrap up real quickly.
Okay, I'll try to go quick. Yeah, this was a very detailed presentation, maybe too much for people who aren't necessarily in Washington infrastructure. So yeah, this is just showing the different groups that are going to be participating in this, the board, the authority, the legislature. I think we've gone over that pretty well. Enrollment, not specified through legislation, but it can use existing infrastructure like Washington Health Plan Finder. You could enroll at the post office. You could enroll with your voter registration. And we have some small business assistance through ESD. Okay. ERISA, this one's more important. ERISA basically means that we can't force employers to participate in this system, but here are things we can do. We can require them to provide essential coverage, and that's one thing we do. So we require employers to cover all their employees, doesn't matter part-time, contract, intern, you must provide coverage. We can say that you must spend a certain amount, and so that's that 10.5%. We can say that certain spending counts, certain spending doesn't count, and we can cover all kids and families. And so that's another great thing is we don't require those family plans anymore because kids and spouses will all be covered individually, and therefore employers won't have to cover those family plans. And we designed this workaround after Healthy San Francisco, which is a city option program, which has survived legal challenges based on ERISA. This is showing that required expenditure. So you see a required expenditure of 10.5%, but that can be private insurance. It can be direct funding of healthcare costs. It can include things like the Long-Term Care Act, which already exists. So employers who are paying into that already have part of it covered. And then anything that, if they fall short of that in any way, so they're paying 7%, right? The difference gets paid to ESD and goes into the trust. But the other option is they just pay the full 10.5% into the trust, and then all of their employees are covered. Okay, the transition plan. This is where we create some of those transitional plans that people can enroll in. But I think the more interesting thing is the integration of Medicare. So the commission identified sort of 6 different options for integrating Medicare into a state plan. And I think the thing to understand about these is that they are not mutually exclusive. So we can do multiple of these. And basically for us, we think that, a federal waiver, that's number 2, is the goal. And that really would allow us to just integrate Medicare enrollees and funding into the system. But short of that, we can basically introduce that health options program, direct reimbursement. That's number 6. So that's the health options program. And then Medicare Part C and D. basically creating a plan on the Medicare Advantage marketplace so that anyone enrolled in traditional Medicare isn't forced into private Medicare Advantage plans to get, say, their dental, vision, hearing covered. They can enroll into a public plan and get their prescription drugs and the rest of their coverage through a public healthcare system instead of private insurance. And I think the really, really important thing to understand here, a lot of people say you need to get these waivers before you can create the system. The truth is the exact opposite. You must create law, you must pass legislation before you can apply for the waiver. The waiver must be applied to an existing proposal. And so we think that passing legislation is the next step for acquiring these waivers. The health benefit exchanges, so this is like the ACA exchanges. They subsidize a lot of the plans on there. And effectively, what we would want is all of that federal assistance to go directly into the Washington Health Trust. And basically, once we achieve 51% enrollment of Washington residents into state-managed plans, we would then shut down the exchanges, not exactly shut them down, but we would basically funnel everyone into the health trust at that point, and all of the cost assistance would go into the Washington Health Trust. So that's one way we roll a lot more of the federal funding into the plan. And just for context, we're not talking about going from 0 to 51%. 40% of Washington state is already enrolled in one state plan or another. So we're really thinking that that's something we can achieve in just a couple of years. This is a year-by-year breakdown, so I'll try to make it simple because there's a lot that goes on. But in year one, we basically just start by collecting the revenue. By year two, we begin to accept enrollment. By year three, we begin to phase out some of the private spending. So some of the private spending will no longer count towards that required spending, and employers will be forced to pay that into the public trust. By year four, all employers will be required to pay the required expenditure. And then by year five, this is kind of the most, this is important, which is that the funding that we propose is required for the first 5 years. It is designed to develop a surplus, and within 5 years, the Health Trust Board will be given the authority to make adjustments to it. And the reason we require it for 5 years is because we want to develop that surplus, and we really want to make sure that this is not killed through underfunding. And so once the trust is established and has its funding, then we believe that if there are surpluses, if there are adjustments, we can begin to do it then, but only then. So going back to the idea of this is...
We're down to just a couple minutes, Andre. I'm sorry. I don't know what to do here, but I have to make an announcement. Can you wrap it in 30 seconds, Blood?
Yeah, 30 seconds. The Washington Health Trust establishes a single benefits package and a public option that can immediately begin to cover everyone. It outlines a framework and transition plan through voluntary enrollment, employer participation, and integration of state and federal programs, which can achieve universal single-payer healthcare. And just like Canada did it in one province, we think Washington can do it in one province, but take that to the rest of the country, create a system that we can be proud of. Thank you very much, everybody.
Okay. Thanks, Andre. I mean, that was brilliant. A lot of detail. I wanted to have more Q&A opportunity here. We do try to keep this to an hour just out of respect for everybody's time. But having said that, I did drop into the chat some Sabuca-related issues that we need to be aware of. And then I'll swing back to you for final word, Andre. And that is that Representative Khan is going to be dropping what's called a co-sponsorship Dear Colleague memo on Monday, the 18th of this upcoming 18th, September 18th. That's going to be in 3 weeks. We want everybody here to be lobbying their members of the House to become original co-sponsors so that their names will appear at the top of the bill when it's actually formally introduced in point 3, which is on October 9th. We'll continue lobbying both the U.S. House members, and also we want to recruit a U.S. Senate member to introduce a companion bill, the same basic bill in the U.S. Senate where we have a chance of doing hearings because the Democrats are in the majority. And then we want to encourage folks to lobby your members both in the House and the Senate through our one-click politics. Mike, if you can attach something about one-click politics and through social media, for example, Twitter, every politician, the phone numbers there, and local congressional district office visits, and contact me directly. I'm here in DC. This work.
You're breaking up a little bit, Chuck. You might have to take down your video.
Sorry, what?
You're breaking up.
Okay. Okay, I hope everybody caught that last part. Just make it, save the chat so you've got all this basic information. I tried to consolidate it. We also have a brochure that we've just created, and I've got a business card that people can use as a template if you want to card for lobbying purposes. If we can try to go on for 5 more minutes, but let's at the time. We can Jody, Paul, Diane, and then I think Anne, and really keep your questions to 10 seconds so that Andre can answer them also in 10 seconds as best we can, just to get through them. And leave your email in the chat so Andre can follow up with you. Okay, so that we keep the conversation.
Hi, Andre, this is Jody. I just wanted to ask you, I hope you're well. I'm sorry I don't have my camera on, but I wanted to ask you about Senator Hasegawa and whether he's going to be refiling Senate Joint Memorial or Resolution 8006. Do you know this session?
Yeah, well, it doesn't need to be refiled because we have 2-year sessions in Washington State. So it's still in the legislature. And the hope is that it will continue. It was stopped in the House, and my understanding is, the only thing we were told was they didn't have time for it. Next session is a short legislative session. And so we're hoping that we can get started on that a little earlier and build off of the progress that we made and get it through. I need to set up a meeting with Senator Hasegawa to make that happen. But the hope is that we kind of know that there's a longer path passing something like the health trust through legislation, but the joint memorial is a really good way to sort of get legislators started and on board with the idea of voting on this stuff. So we do think it's a great way to sort of move things forward.
Okay.
Yeah,
Paul,
we really lobbied hard on that with our members, and so we'd really like to use that as a sort of as a vehicle for education. So I will contact his office too, Andre, and appreciate all your work on what you're doing. Really appreciated.
And Andre as well, leave your contact info in the chat before you leave. That would be helpful so the conversation's both ways. Paul, you have a quick question about to the Washington State system. Paul, real quick. And if you're not ready, Diane has a question about different public options. So either Paul or Diane, whoever's ready to jump up.
My question was already answered.
Okay, great. Diane, do you have were you satisfied with your?
Andre already answered my question. I was concerned about different public options because it creates the potential for loopholes in the safety net. And his answer to me with this is that this is a transitional factor of the program, and eventually it will become one basic plan for everybody.
And that's really what we mean when we say that transition from Model B, an all-payer model, into Model A, which is a single-payer model. And yes, I'll put the link to the slides in the chat because they're available at wholewashington.org.
Okay, all right.
/UHCC presentation.
Okay, and again, on the rollout with Kana, there are 2 links that Mike put for one click politics, one for House members. That's a different method, and then Senate members. So if you can just click on those hyperlinks, that'll get you right to our one clicks politics page. And then Andre, just final word, and then just to keep people in touch and conversation, going forward. Just a real brief closure. Thank you. Thank you for coming today.
Yeah, I guess I would just say that I truly believe that this design is something that can be built off of in every state. you know, I think that the key challenges are always the same, and that every state is different, but also our effort is greatest when we are all working through the power that we have in our state governments, and ultimately the system of our dreams, where this is done, you know, a federal program that will still be done through participation through state and federal systems. There's not just one place that this happens. We need this at every level of government. We need everybody on board. And so please do take these lessons back to your groups out there. Please take them to your legislators. Please keep demanding this, and don't let anybody tell you that this is not possible. It is 100% achievable. And I am just so grateful to be joined by so many people who believe in it as strongly as I do.
Terrific, Andre. Thank you. And thank you everyone for coming today. Let's get rolling with Sabuca over the next 6 weeks at least, the private, the circulation phase, and then the rollout phase on October 9th. We got to get to work. Let's get that done. Thank you so much, everybody. Radical hope, hospitality, and love. Winning strategy. Let's do it. Thank you.